Nah. Hello, hi, can you hear me?
Yes, sir.
Yes, sir.
Good.
Yes, sir.
I
Yes,
was
sir.
trying to look for Dr. Biswas on the group, and then I realized Lenovo. Sir, how are you? Sir, put your volume on. You have to switch on your microphone. Dr. Biswas, yeah, that's good. Good, sir. Now we can see you. How are you, sir? Can you hear me? Can you hear me, sir? Dr. Babatosh, can you hear me?
The Babatosh sir microphone is off.
Microphone is
I
off.
told him, but he's not. Sir, switch on your microphone. Switch on your microphone, sir. We need your microphone to be on. I can't hear you, sir. You'll have to switch on your microphone. Let me call you.
Yeah, now it's okay. No, still no.
Sir has to dial in via device audio.
Call in via device audio.
Everybody relax. I'll sort it.
Yes, sir.
नहीं बट
Can't hear you, sir. We cannot hear you. Pick up your phone.
Yeah.
Pick up your phone, Dr. Babatosh. I am talking to you. I want you to pick up your phone. Pick up your phone. I can't hear you.
मैं हूँ जियो 5 पे हूँ। हाँ मैं जियो 5 पे हूँ।
Yeah, now your microphone is on, but we can't hear you. I don't know why. My suggestion is log off. My suggestion is log off and start again. Just log off from the call and start again. Dr. Babatosh, you will have to actually log on onto your laptop, not on your phone. I cannot hear you at all. Okay, all new people to this call, please switch off your microphones. Hello.
आवाज कहाँ से आ रही?
I don't know if you're logged on or not, Dr. Babatosh. Please take my call. My phone is ringing. Please take my call. I'll be able to guide you. Yeah, sir. Okay, so sir, log on using the link that I've given you. And you need to use the microphone. You have to log on using the microphone of your device. So yeah, we can't hear you at the moment. I can see you, but I can't hear you. Can you see me on your laptop? I'll guide you through how to go through it. If you can see me, I'll share my screen. Yeah, log off and log on, and then I'm sharing my screen. I'll show you what to do. Yeah. Sorry, guys, we have a little technical issue. We will solve it in a minute.
શાંતિથી બધાને ખવડાવતો 1 કલાક લાગે પછી સેવ નાખી દઈએ પછી મજા ના આવે.
I'm just waiting for Professor Babatosh to log on. Just give me a few minutes.
मेरा ईयर प्लग
Bhushan, are you on this call? Bhushan, are you on this call?
Yes, sir.
Acha, do you know what Babatosh's ID is? I can't see his ID in the list.
আপনার ভিডিওটা স্যার নিচে ক্রস করা আছে নিচের ভিডিওটা ইয়ে করুন
Windows laptop it is there.
Is
I
that
have
this?
SMS. I have SMS team.
Yeah, Bhushan, you phone him and guide him through how to log on. Just phone him and guide him. I can see a Lenovo. I don't know if that is here.
Lenovo is a phone.
Yeah, so I don't know why he's logged on with the phone. Just guide him. Or if he wants to come online, I will share my screen and I'll show him how to go through it.
Yes.
Phone him, Bhushan. Just phone him on the side and talk to him. I don't know why he's on a phone. He should be on the laptop. We did the trial run the other day. Request to everybody who's logging on now, please switch off your microphones, except mine and Professor Biswas. I want everybody to switch off your microphone. There is an icon at the bottom which says mute. Please mute your microphone. Arif, he's your boss, isn't he? Arif? Can you hear me? Nikhil, can you hear me?
Yeah.
Yes, sir, I can hear you.
Okay, so why is Arif not responding?
Arif?
It's okay, don't worry. I want Dr. Biswas on the call. I don't know what's happened. He came on and then now he's not there. So I don't know what is
Bhushan must be talking to sir.
Yeah, I'm trying to call, but he's not picking up his phone. Ah, sir, bolo. I can hear you on my phone, but I can't see you on the screen. Have you logged in, sir? What is your ID? I can't see your ID, sir. Is it Lenovo? Is that you? Is that your laptop or is that your desktop? Guys, can I request everybody to switch off your microphones because I need to identify which is his microphone. Everybody, please switch off your microphone if you can hear me. I'm not able to identify because he's not put his name. So just switch off your microphones. I want only one working microphone, that is his and mine. Come on, guys, not that difficult. Just switch it off. At the bottom, there is a mute sign. Just switch it off, please. क्या हुआ, sir? What is your ID? I don't know, sir. What is your ID? As long as there's a name there, I can't identify. I got more than 40, 50 people, so I don't know where you are. I need to know your ID, sir. What ID is your? Have you put a name to your ID? Is it Lenovo? I don't know which one is your ID here. Hello?
রে তোর রান্না হইছে?
Guys, please switch off your microphone so that he will come to the top. I cannot identify in a group of 100 who. Sheikh Muhammad, switch off your mic. I can't do this. Come on, guys, quickly move and switch off your microphones so that I know which is sir's microphone. Dinesh Kumar, who is Dinesh Kumar? Just switch off your microphone, please. Frustrating. Hello? I could see you earlier, sir. Now I can't see you. I don't know which is your ID. I can't see you at all, sir, at the moment. I can hear you on the phone, but not on the call. My problem is I don't know what you have called yourself on the call. So I don't know what is your ID. I'm trying to identify. There are about 100 people, so it's becoming difficult. Who is Dinesh Kumar? Don't switch off your. Just switch off. Don't switch it back on, please. I think your one is called as Lenovo, sir. I'm not sure. Yeah, this is you, I think. I'll make you the host. Let me see if that works. Yeah, that is you. Hello. I'm very sorry about this, guys. I'm just trying to get Dr. Babatosh online. Okay, I can see that you've just logged on. Can you switch on your camera, please? Yeah. Yeah, I can see you. Good, good, good. So good. Yeah, I can see you. There is something wrong with your volume. So I'm going to share my screen with you, okay? And just do what I ask you to do. Go into this zoom.us. Can you see that? I've just clicked on it. You click on it. Go into preferences and look at your audio. Yeah, test microphone. If you see the color turning to green, then your microphone is on. Is your color turning? Because we can't hear you at the moment. I can't hear you at the moment. Test your speaker also. You go into this, which I'm showing you, and put same as system. Same as system. Yeah, mine is AirPods, but you put same as system. Or you can put it built-in internal speakers. The same thing, you go to the microphone and do built-in internal microphone. Have you got headphones? Why don't you connect headphones? Just for the minute, connect headphones. Let us see if that works better. No, I can't hear you, sir. I can see you, but I can't hear you. Yeah, sure. Take your time. Don't get stressed. It's okay.
Take your time. Complete dominance.
Did somebody say Bappa? Do you think that's the name? Guys, hello? Priya, did you leave a message saying he is Bappa? Nikhil, can you hear me? Is my voice clear?
Yes, sir. Your voice is very clear.
Okay, then the problem is at his end. I think his laptop setting is what it needs to
Yes,
be.
sir. Actually, at the start, he has to log in via device audio.
Yeah, but you can change it on Zoom preferences. So
Yes, sir.
that's what I was showing him. You can change on Zoom preferences.
Otherwise, just ask him to share his desktop and we can you can manage, sir.
No. I can't do his lecture. He has to do his lecture. He cannot
No.
share his desktop.
If he shares, you can switch on the settings. I mean, the device audio.
No, this is not Team Viewer. So this is, you can do that when you're using Team Viewer.
Yes.
On Zoom, you can't do that. That's a different software. It's called a Team Viewer. Hello.
Sir, even on Zoom that day, I was able to control Nikhil's laptop.
Yes, sir. We did that, sir.
Okay, I'll tell him. Dr. Babatosh, can you switch on your, can you share your screen with me?
Assalamu alaikum. Ramadan Mubarak, sir.
Walaikum assalam. Dr. Faisal, just 1 minute. I'm trying to solve Dr. Babatosh.
Just came after completion of Taraweeh.
Yeah, wallahi. Okay. Dr. Babatosh, can you share your screen with me, please? Hi, Dr. Babatosh, can you hear me? I want you to share your screen with me. There's a green button on the bottom. Share screen. So if you share your screen, we can see your screen. At the moment, we can't see anything. Hello? Hello? Share screen, Dr. Babatosh. Please share your screen and I'll try and help you. I can see him now.
Can you hear me now?
Yes, sir. Yes, sir. Put your video on, sir. Start your video. Excellent. Now you're talking. This is Apple laptop, isn't it? So that is the difference.
This is Apple.
There is no other laptop to buy except Apple.
No, initially I started level, but some problem happened, so I changed it.
All right. Okay, sir. You need to click on your green button downstairs called a share screen.
Yes. Done.
Is your PowerPoint on?
Yes, PowerPoint.
Switch on your PowerPoint on the Apple laptop. Switch on your PowerPoint. Very good. Okay. So now stop this. Stop all of this in front. Stop this. Bring up PowerPoint. Yeah.
Just bring.
Yeah. Bring up PowerPoint. That's good. Nice. Click on it. You can stop Safari. It's all right.
Yes.
Just click out of Safari. You don't need it anymore.
It slide receiver.
Just play your PowerPoint at the moment.
I see. One na jagra ko to share with Cisco. Screen share kar. Is it? ছেড়েছি ঘর ভাই কোথায়?
Sir, put your secretary's phone off. Listen to me. Okay, that's good. And now go into play. Play the mode. Slideshow on the top. Slideshow. This one. Slideshow.
সব অফ হয়ে গেল। Just hold on.
Restart. Don't send.
Just give me a minute. I'm just sending.
Don't send this. Just switch off all these things in front.
Just hold on.
No Excel, sir. You don't need Excel.
It's okay. Slide down, go. Is it visible now?
You have to share your screen, sir. Share screen.
Doing that.
Share screen. There's a green button at the bottom called a share screen.
Yes, sir.
And when you click on that, you will see PowerPoint come up. Yeah. So now play slideshow. On the top, slideshow. How we normally just play a slideshow. That's what you have to do. No. On the top, slideshow. Look for slideshow. More to the right. Yes, that's the one. Click on it.
Okay. Is it visible?
It's thing at the bottom, at the
bottom.
You can see this icon, slideshow. There are three icons here. Come to the left
side, third one.
1 minute, wait, just one person talk. Come on the PowerPoint. Yeah, come to the left, three icons. This third icon on there.
Can you see the slides?
I can see the slides, but you need to play slideshow. It will work better for you.
I'm just manually clicking. If you can, you can see.
Listen to me, Dr. Babatosh. Don't get stressed. Go to the left-hand side of your screen.
Some problem is happening.
No. Come down. I can see your cursor. Come down.
Can you hear me?
To the bottom. I can hear you very well.
Can you see the slides?
Yes, we can see the slide. But just come down. Listen to what I'm saying. Just come down to the. Yeah. Bring your cursor down. Move your down to the left corner. No. Come up a bit. Come up. No, don't use the bottom bar. Just come up. Yeah, there are three small tabs on the left lower side here. Yeah, that's it. The third one.
This one.
Yeah, that's the one, sir. That's the one. Yeah, good.
Okay.
Excellent. Okay, not to worry. Let's just get on with it. We can see you very well, and just work it. I think this Abhishek has to switch off any desk. He is controlling your laptop. That is the problem.
Just let me switch off the Lenovo.
Yeah, but Abhishek has to switch off any desk. He is controlling your laptop at the moment. That is why yours is not working.
Is it okay now?
Abhishek, can you just switch off your any desk?
Yeah.
Okay. Is it okay?
Yeah, it's okay. It's okay. Don't worry about it. Just carry on.
Am I audible now?
Yes, you are audible, sir.
And
if you can play the slideshow, that'll be good. If you can't, then we can see what you're doing. So it's okay.
let me check slides. Yes, I can change the slides.
Okay. So let's work with this.
Okay. And you can hear me and you can see me, isn't it?
Yes, sir.
Okay. Let's
all right.
I'm
okay.
sorry.
So, ladies and gentlemen, it's okay. Ladies and gentlemen, thank you very much for your patience. It's actually an honor and a privilege today to moderate a session by none other than Professor Babatosh Biswas. Professor Biswas is not a guru, he's a Mahaguru. As I put in the background, you can see he's actually the Mahaguru of thoracic surgery. And he's going to talk to us today about emerging challenges in thoracic surgery. And all of the slides are his personal cases, all the difficult cases that he has faced over the years. So, Professor Biswas, the floor is all yours. Take it away. Please enlighten us on your.
Thank you, Dr. Javeer, for this great introduction. And I'm really sorry for the hassle of what happened in the beginning. So
don't worry about it.
I believe now I'm visible and audible. And let us spend some time on discussing my experiences and my problems, what I felt during the practice of thoracic surgery. I believe a lot of our friends on the screen, they will spend some time with us. And during this period, we'll discuss just day-to-day problems, what we face as a challenge in the practice of thoracic surgery every day. So let me start by saying that thoracic surgery is not a new one. It has crossed almost 100 years. In 1923, successful lobectomy was done for CA lung by Graham. It was 1923. But the technique was early technique, which took a couple of years to be perfected. By 1930, it got perfected for lobectomy of lung cancer and TB. And what I reviewed, what are the challenges, what are the problems in thoracic surgery? First issue, that for thoracic surgery, we have to take control on the airway and ventilation. We are operating on lungs, so unless we have full control on airway, it is difficult or not possible. Next, in my feeling, we must be able to locate the disease very nicely, and that is by imaging. Imaging has gone long way. So I will spend some time on the utility of imaging. Next, how to reach the lesion, the approach. And third, how much to resect. These are the areas must be addressed properly. These are the challenges. Sometimes it may not be easy. Most of the time it is easy that we are going for lobectomy or pneumonectomy or thoracotomy or sternotomy. But sometimes it becomes a really challenge. Let us see one by one. The airway control, that the endotracheal intubation and closed circuit ventilation started almost 100 years back. That is 1910 to 1920. That is the period when endotracheal intubation started. But it was both lung ventilation together. Then the first came the double lumen endotracheal tube and one lung anesthesia. That is introduced by Carl Lenz. That is in 1949. That was the, almost this in 1949, the double lumen endotracheal tube was introduced by Carl Lenz, and that makes a huge difference in thoracic surgery. And that double lumen, these are known to all thoracic surgeons. This is disposable double lumen. And then these are old generation when first came right side, left side, reusable. And this is, I am not going into details, a double lumen put, it is checked by pediatric fibroscopic bronchoscope, and it gives you the occasion for ipsilateral lung collapse. The side which we are working, that side is collapsed and the other side is inflated. And these are the issues that is related to airway access. Whatever surgery you do, maybe thoracotomy, maybe VATS, whatever you do, first we have to take control of airway, lung inflation. So we should get enough space, sufficient enough to handle it, either by open or by minimal invasive. That's a major challenge first we have to address. Next issue, as I told you, imaging. We must locate the lesion, be it malignant lesion, be it inflammatory lesion, be it cyst. So first, the gold standard, definitely X-ray today. X-ray till gives you a lot of information to start with. Definitely you have got other imaging modalities that gives us full information. This X-ray, this chest is simple X-ray, we can see these opacities, one overlapping the other. There are two opacities on the right side, and just in a rough idea we can make, the entire right lung field occupied by opacities, one overlapping the other. Maybe cyst, maybe something else, is the first idea. The same thing on the right side, you can see another opacity. So these are the first information given by chest X-ray. So another X-ray, if you look at this image clearly, this is pulmonary and this is another hepatic. So these are hydrated two sides, but I am not interested in diagnosis at this moment of time. I am going to discuss the importance of very, very preliminary image, that is X-ray. Next step, that is computed tomography, that is CT scan. That gives a lot of information. That is the mediastinal window, lung window, and construction. So here we can see this lesion here. Another lesion, we can see this side. So with this detailed about the lesion, we can visualize on detailed images. So these are the different lesions, whether it is now detailed analysis and other parameters will be able to tell us whether it is solid or single, multiple occupying different parts. So these are the, say in this image, you can equal a lesion, another equal lesion. So this CT scan give you a lot of information regarding the lesion inside. So after taking control of airway, next time you have to understand the pathology of the lesion and to localize it. Then comes the approach, how to reach. Just after brief introduction, I will go into details. Brief approach, because our target is to localize the lesion. Our target is to correct the disease. There cannot be any compromise. And for that, we can reach by opening the chest, this is thoracotomy. Or we can, if it is lesions bilateral in the chest or in the midline, we can go by sternotomy. And definitely thoracoscopy or VATS is a huge role, and the robotic surgery has come. So all these are access. There are definitely advantages and disadvantages. There are basic things. The thoracotomy, sternotomy gives us to big structure, big scar, pain, etc. And thoracoscopy and over, these are the images. Now, with this background, that we have taken full control of airway, we have localized the disease, we have entered the chest by whatever means, either robot or VATS or open. And now we are just taking the challenge one by one. The next issue is, as we all know, that lung is very valuable organ. We cannot afford to take much lung. So for lung, we have got very, very conservative approach. We take minimum lung, say for different disease, the policies are absolutely different. For malignant disease, lobectomy is standard. For other inflammatory disease, we cannot resect the lung. For hydrated cyst, we don't take out lung at all unless there is compulsion. Only closure of bronchial orifice should be enough. So this is a picture where we have seen just a segment of the lesion. Another, this has taken the lobe of the lesion, lobectomy. This is entire lung. Unless we are compelled, we don't take out lung. So in many cases, individual case, we have to decide how much lung has to be resected. With this background, let us go one by one, and that will take us to real challenges. What are the challenges thoracic surgery? That every case will dictate, and in each case, we have to take all these points in account. So let us see one case scenario.
Babatosh sir.
Can you hear me?
Sir, this
Yes,
is
we
Dr.
can hear you.
Faizul.
We
Sir,
can
this
hear
is
you.
Dr. Faizul from Bangladesh. Can
Yes.
I take 30 seconds to talk with you in Bangla?
বলুন বলুন নিশ্চয়ই।
স্যার আপনি আপনার স্ক্রিনের জাস্ট নিচে একদম বাম থেকে 3 নাম্বার ফুল স্ক্রিনে একটু ডাবল ক্লিক করলে ফুল ভিউ চলে আসবে স্যার, তাহলে ফুল স্লাইড শো আসে আর কি।
তাই তো আসে।
No, Dr. Faisal, there is a problem with this computer.
Okay, sir. Okay.
It's okay.
Okay, sir.
He's tried that before. He's not able to get control. Sir, please continue with your talk.
So let us take a couple of case scenario. Am I visible?
Yes, sir.
You can see the slides and you can listen to me. You can hear me, isn't it?
Yes, sir.
Okay. So I am taking couple of case scenario which will really analyze the challenges. This is the congenital lobar emphysema. As all of you are aware, but these are very, very pediatric patients, very small infants. The problem starts in the very beginning of life. Patients come in the age of 1 day, 2 days, 3 days, but most of the patients come between 3 to 6 months. Either you have to identify the disease, you have to address it, or you are going to lose the patient in most of the cases of congenital lobar emphysema. This is very, very interesting case. Let me see this scenario. Most of the patients in very, very young infancy, 1 day, 2 days, 3 days of birth, they come with severe respiratory distress, acute respiratory distress. A baby suddenly starts difficulty in breathing and it worsens progressively. If we are unable to diagnose or handle properly, there is every chance of losing the patient. Look at the X-ray. First, if you look at the X-ray, the right side is hyperlucent, the mediastinal looks shifted, and left side little bit hazy. Let us look at the CT. This gives you good information, full information. This is the hyperinflated lung. This is not normal lung. It has herniated through the anterior mediastinum, reached the other side, and the whole mediastinum shifted to the other side. And this is the normal lung, compressed, and another portion, the healthy side, this is normal lung. So this portion is normal on the same side. This is the normal lung on the other side, and rest of the lung which is seen, this is not normal. This is emphysematous lung. This lobe has hyperinflated, and this pushes the lung on the same side, pushing the mediastinum, pushing the other side. This were very sick, progressively increasing respiratory distress. It has to be identified immediately to be operated. However, cases with very minimal symptom may survive the adulthood. Those are very, very fewer patients, but most of the patients with congenital lobar emphysema, this is the clinical picture. So here, once the diagnosis is made, and the strong suspicion is the most important to women, the challenge is to identify. A lot of babies come with serious respiratory distress, thought to be many other medical illness, but it is difficult to identify, and major challenge comes. Many times it is misdiagnosed as tension pneumothorax, and by mistake chest tubes are put. That makes scenario still more complicated. So once it is identified, the treatment is to operate this, to resect the emphysematous lobe. The challenge is to identify the healthy lung and to put into surgery. And this picture is self-explanatory. Patient is very unstable hemodynamically. You take a decision, you make a diagnosis, look at the X-ray, some capacities, and once you identify this, we have to do thoracotomy very, very urgently. Sometimes during anesthesia, on when the anesthetist is going for anesthesia, sometimes it is awake after oxygen and inhalation anesthesia, no muscle relaxation, and very quickly we have to go in, and the lobe, which is emphysematous, comes out. As soon as the lobe herniates, the hemodynamic settles. The lobe is seen, huge lobe, much bigger than entire lung on both sides. Once it comes out, anesthetist inflates the remaining lung, and that settles the issue. The rest of the surgery is very simple. You do the lobectomy. This is the hyperinflated lobe, lobectomy, and the post-op exercise like this. These are absolutely normal lung. So in this case, the challenge is you have to identify. It is not tension pneumothorax. It is congenital overemphysema, and the patients are very unstable hemodynamically, has to be taken to surgery and to operate very carefully. Early part is very stormy, but once you have been able to do thoracotomy and the lung is allowed to herniate, rest of the things settle very quickly. Let us come to second picture, very similar picture. This is an elderly patient with COPD, and patient gets gradually increasing respiratory distress. And chest X-ray and CT, if you look at this chest X-ray, this is localized air pocket here. Look at the CT. This is classical lung bulla. This partitions confirm this is bulla. This may confuse with tension pneumothorax. The challenge is to make a real diagnosis. If it is taken a tension pneumothorax, if a drain is put, that creates a lot of problem. Continuing air leak and bronchopleural fistula. And in these cases, the diagnosis has been made. It has to be made sure that it is not tension pneumothorax, it is bulla. But surgery is very simple. Earlier we used to do thoracotomy and bulectomy. Now minimally invasive, your heads and the robots with a knapp and open heads or anything. Bulectomy is a simple process, but it must be identified. All these cases are treated as just like emphysema and bronchial asthma and sometimes tension pneumothorax. And in operating field, as soon as thoracotomy is made, this bulla peeps out like this, herniates like this, and lung expands and the emergency settles. So bulectomy is very simple surgery. And for that, thoracotomy is not needed now. Most of the people are able to manage with minimally invasive approach. But this bulla expanding inside causes pressure atelectasis on the rest of the lung. So challenge is to identify, to operate properly, manage the early part before the patient goes in problem. Now let us come to another issue which I will just touch but not go into details because that will be discussed on a separate day. The tracheobronchial stenosis, mostly post-intubation tracheal stenosis. There's a common problem now. A lot of patients come and trachea doesn't have substitute. Trachea has to be resected and it has to be repaired. Professor Rajan Santosham will be going to discuss next day, so I'm just limit. So this is really challenging case and trachea can be resected nicely. Rest details you will learn from Dr. Rajan in next couple of days. Let us discuss very common disease, hemoptysis. Hemoptysis is a regular problem for the thoracic surgeon. It may be small hemoptysis, it may be recurrent moderate volume hemoptysis, or sometimes may massive hemoptysis. Massive hemoptysis is a real problem. Massive hemoptysis, underlying disease is one issue, and the blood, if it is expectorated out, patient survives. A lot of blood collecting in the airway may choke the patient and patient may die of asphyxia. And hemoptysis has got several important causes. We have to look the hemoptysis and we have to find out the option for that. If it is massive hemoptysis, that is whatever may be the underlying causes, I will come one by one. Massive hemoptysis, in that clinical scenario, surgery is indicated most often as a life-saving measure. Currently, there is another option, that is bronchial artery embolization. But bronchial artery embolization is usually a mode which gives temporary relief. You get some time, purchasing time. In hemoptysis, the bronchoscopy, CT scan, everything is done and that gives you diagnosis. But for hemoptysis, you have to localize the disease and rationalize whether it is right side or left side, or it comes from upper lobe or lower lobe. Many times it is very difficult to find out from which lobe and which side is coming. Unless it is identified by CT or bronchoscopy, it is very difficult to handle it. By bronchial artery embolization, bleeding may be stopped temporarily. By that time, we have to make a full homework, find out the lesion, and handle adequately and do for surgery. Couple of hemoptysis I will now just discuss here. This patient, this destroyed lung, that is very important clinical problem, and we come across in our day-to-day practice in this part of the world. Unilateral destruction of the lung usually happens in this country and this part of the world due to tuberculosis, still common. It is a sequelae to long-term sequelae tuberculosis, but it may happen in non-specific infection also. There is fibrosis inside the lung, the atelectasis, and there are lot of adhesions. Whole lung is made in a sheet of leather-like tissue, and it is exactly the bronchiectasis and lot of cavities. Chest X-ray give you primary information. There's volume shrinkage, it becomes smaller. There are cavities, there is fibrosis, and whole lung or a lobe of lung may undergo destroyed. We are now talking here about destroyed lung. The whole lung is gone. These patients, these cavities get recurrently infected. When the destroyed lung is a presenting symptom, usually tuberculosis is not active. It is sequelae of tuberculosis. So these patients come with recurrent infection, foul-smelling sputum, and they come with hemoptysis. This hemoptysis may be recurrent small amount of hemoptysis, or it may be profuse hemoptysis. When it comes with profuse or massive hemoptysis, it becomes a really challenging problem. Let us see a little case scenario. This gentleman, Mr. Tony, he's 75 years. He's a very fit person. He had recurrent bouts of hemoptysis. Looking at his extensity, he was denied surgery because it will be very high risky. He had cardiac problem, he had many problems. So he was maintaining. Someday he had profuse hemoptysis. He was admitted, and just I will go through a couple of pictures. See, this is CT. This is the entire damaged lung. Whole mediastinum shifted to the other side. This is the entire. This is the vascular structure. Aorta. See, this bronchus is totally cut. This is disconnected, and the whole lung is bronchiectatic like this. This is absolutely dangerous. If this patient has got profuse hemoptysis and bronchial artery embolization may give temporary relief. If you cannot make a plan and if we are unable to resect it, this patient is going to die. Whatever problem he has, we have to manage it. See, I am going to see the problem. See, this is the pulmonary trunk. This side it is going here, and this side is stopped. Just I am concentrating on this picture. This is the pulmonary trunk. This pulmonary artery going to the other lung, and this is blunted, and this area is aneurysmal. And this is a arterial connection here. The patient came with profuse hemoptysis, and other measures failed. Bronchial artery embolism was done, it was referred, and then when I reviewed the entire CT plate and pulmonary angio, CT angio, there was hardly any space on the lateral chest wall through which we can enter. There are two problems. One is there will be extensive bleeding due to collaterals, and all the tissues are flooded with multiple neovascularization. A major issue, the aneurysmal pulmonary artery, this is occupying just like a snake sitting on the wall of the chest, inside the wall of the chest. To get an area inside the chest is difficult. After reviewing the entire CT very, very carefully, we find out the space through which we can enter, making a thoracotomy, small area, gradually increasing, dissecting very carefully. And then once you cover the peripheral area, central area is not so difficult. Here, major challenge in my feeling that is entering the chest is more difficult. We have to find out the area. While in the effort of opening, if we go through the major, first is there are a lot of vessels that will give terrible bleeding. That if we enter some major vessel like pulmonary artery, aneurysmal pulmonary artery, that ends the job. So entering the chest is difficult. We have to safeguard vessel. We have to assure hemoptysis. And once we enter the central area, that is close to hilum, rest of the surgery is difficult. The thoracotomy has been the usual traditional technique, but doing this with minimal technique is also now practiced with experienced hands. And like Jamir, it can be taken nicely. But major issue is we have to handle all the bleeding. We have to take care of major vessels. These are the major issues here. Once we are resected, the entire lung like a solid structure, and these are the bronchiectatic areas. These are the bronchus is just like tubes, thick tubes. These are the all bronchiectatic, and the whole lung parenchyma is a sheet of leather-like tissue. So these patients may come with any age, maybe a sequel of tuberculosis, maybe infective. When they come with profuse hemoptysis, it is really a challenging issue, and we have to identify the disease, and we have to think of very nicely which should be proper route to enter the chest. And once we are able to take control, this lung is already gone. He was serving on one lung. So once it is taken, the rest of the life of the patient will be very safe. Let us take another patient of hemoptysis. And this patient finally came as thick wall cavity fungal ball. And this patient is more than 60 years old, elderly female, and she was a social discard because she was producing foul smelling sputum, and people around her was very, very annoyed. And interestingly, with this problem or recurrent hemoptysis, she was taken for surgery 27 years back. The profuse bleeding, in those days, 27 years back, a lot of things of current day thoracic surgery were in primitive stage. So due to huge bleeding, after a couple of hours effort, the patient was closed with packs, and finally patient survived. But what happened finally, patient used to produce lot of sputum, lot of dirty sputum, and the patient was tolerating that. And one fine morning, profuse hemoptysis. So profuse hemoptysis, dirty sputum, social discard, these are the issues patient came. And just I have put one next to here, very, very thick walled cavity inside. And this cavity, when we analyze the entire CT series, it was connecting to a bronchus, and that was the source of profuse foul smell sputum. This cavity was getting recurrently infected, tonsil sputum, that was dirty sputum, that was foul smelling, and she was practically social discard. And that was what she was tolerating. But once the profuse hemoptysis started, there was no option. She came, and the challenge was the same. It was extensive dissection. The patient, which was brought down from table due to bleeding, extensive bleeding could be managed. That patient, that was the major challenge. And the long period of this cavity staying inside, so must be a lot of addition, lot of bleeding, lot of technical problems. So challenge were very, very difficult hemostasis and extensive dissection. But the problem, if we are able to handle it, we are able to take the challenge, the lobectomy would have been answer. And see, the lobectomy was done. This is absolutely solid lung and very, very thick walled cavity and very huge fungal ball. So tubercular cavity, fungal ball of almost 30 years duration, extensive addition around, lot of bleeding. Patient tolerated this for quite a long time with recurrent bleeding and foul smelling sputum. But once the profuse hemoptysis, there's no option, it has to be taken. So as a thoracic surgeon, you have to take this challenge. You have to identify the lesion. We have to think properly, and we have to go inside and we have to manage it. While entering, if we are not very careful, we are not careful of, we are unable to manage hemoptysis properly, then it becomes a real shit. And more so, I should discuss one issue which will be relevant for next cases also. But these cases are wet cases having lot of sputum inside the cavity that comes out in the tracheobronchial tree, and both the tracheobronchial tree are flooded with foul smelling sputum, dirty sputum. Once the patient is turned to the other side, this sputum enters into the other lung and floods the healthy lung, and that may put you in real difficulty. So before taking this patient to surgery, these patients need to be prepared very thoroughly. That is by partial drainage, the nebulization, the spirometry, cuffing, all these things, these efforts have to be taken. So these are the very important issues. This must be taken properly when the patient is taken to theater. Double lumen endotracheal tube very nicely so that there is no spillage from one side to the other. And very careful meticulous dissection to avoid bleeding for the very beginning. And there is no scope of blunt dissection. It is always very short dissection, either diaphragmatic or harmonic. And those the cases are very difficult cases, but thoracotomy has been the standard technique throughout. But now, in experience and minimal invasive surgery is equally effective initially to make some port enter the dissection with minimal invasive. I have stopped at VATS level only. Now robot gives much better suitable technology to handle it. So these cases are to be taken with challenge. Another patient presented with hemoptysis. He also had recurrent bouts of hemoptysis with foul smelling sputum, and that was dirty. And that patient, that is not very difficult person, male, 36 years. And see, both the lung has got bronchitic cavities. This side small cavities, this side multiple cavities. And this patient presented with recurrent foul smelling sputum. So these are the areas. So both the lungs are bronchiectatic, major areas here. It may be, it is now thick walled, looks like non-tubercular. Tubercular bronchitic cavities are thick walled, but here it is probably cystic bronchiectasis. It is not tubercular, but whatever be is tubercular or non-tubercular, these major challenges, it is scattered in both the lung. One lung, it is more in one lobe. So here, though there is small amount of lung is left with some cavities, but we must be careful to save the lung. Conservative of lung is very important. We have to save the lung. We have to do absolutely conservative lung resection. We have to resect the lobe, keeping very functional other lobe, and the other lung, though having some cavity, that has to be left aside. The major areas of cavity in the form of lobectomy must be done. So look at this picture. There are bronchitic cavities here also. There are lesion here also. There is scattered lesion. There are lesion. But it looks that some amount of lung is here. Looking at all the cities, it was evident that one lobe we can save. So we have to take a lot of pains to save the lobe, and sometimes we have to save segments. One lobe is gone, maybe 1-2 segments, other lobe is gone. So whatever lung is healthy, maybe with little bit of bronchiectatic areas, we have to leave, because that will help us to see this one. These are the areas disease. So this lung we are not touching. This lung is there, this cavity is left, and here after resecting, one lobe will be left. So extensive dissection, and during dissection we must be careful that we should not injure a lot of lung. So air leak should be minimal. There should not be lots of air leak. There should not be bronchial fistula. So dissection must be meticulous. Lung conservation must be done very nicely. And finally, this patient ended with lobectomy. So all these patients have this similar problem: cavity, recurrent bleeding, infection. And the challenge is to make a diagnosis. Challenge is to preserve the lung as much as possible, and that should be on anatomical basis. We have to save a lobe or lobe plus segment or couple of segments, and we should be very, very conservative. Next, another case almost in the same, that is infective. This patient had acute onset, absolutely classical lung abscess. 10-12 days history, fever, chest pain, sputum, cough. That is aggressive clinical course, and as all we know that the acute lung abscess, that is not a surgical emergency. It has to be handled medically. So medical treatment is essential for lung abscess. It was done, but course was very aggressive, gradually progressively increasing blood count, and patient fever, toxic, CRP is high. All parameters suggested that infection is not going under control in spite of adequate antibiotic, chest physiotherapy, then bronchoscopy, suction. In spite of doing everything very, very carefully, the infective phase could not be controlled. And looking at the regular X-ray scan and CT and clinical examination, finally it was thought that it is very aggressive lung abscess, damaging one lobe completely, rotten. And if we are unable to understand this, if we are unable to make sure, and if we don't take out the lung, this patient is not going to survive. He might have profuse hemoptysis, or as a course of septicemia, he can die. So look at this CT. This patient, very aggressive clinical course. This is classical lung abscess. Look at next CT. Gradually, these are the, if you are coming lower down, so whole lung is totally solid, and this is classical picture of lung abscess. So normally lung abscess, we do conservative treatment, and surgery in acute lung abscess is not indicated. But this patient, as I'm repeating the same thing, is a very, very aggressive clinical course of a lung abscess and could not be managed with all conventional measures, antibiotic and chest physiotherapy, bronchoscopy, suction, everything failed miserably. So then we thought we must take it out. Challenge was to establish the indication. As in lung abscess, surgery is not indicated unless this sort of challenge is there. So after reviewing the clinical course and the imaging, we thought it should be aggressive lung abscess should be operated. So conservative surgery, very meticulous surgery failed. So decision was lobectomy was taken and surgery was done. See the lung. The one lobe is totally rotten, totally gone. This lung abscess having such an aggressive course, this lung abscess, this lung cannot recover. So if we are not able to pick up these cases, we are going to these patients. So this is the lobe we have resected due to this aggressive disease. This is a very aggressive clinical course. This sort of bacteria, this sort of infection, lung absolutely under necrosis for a quite long time. The clinical course are very short. So these patients need to be identified. So surgery may be required in very, very selected cases of lung abscess, where the clinical course is very, very challenging and cannot be managed with conventional measures. After that, this infective picture giving rise to mostly hemoptysis and infective pictures. Let us localize some other area. Let us look at thymoma. This thymoma is a very, it is not uncommon. As asymptomatic, a patient came with the features of myasthenia. This is asymptomatic. Initially asymptomatic, then started the eye symptoms, and early symptom myasthenia, then CT was done, and earlier asymptomatic, then came and diagnosed with a solid tumor within the right lobe of thymus. And here, the taking out the thymus is very easy. By whatever route you like to do this thymectomy, very, very simple sort of surgery, but same thing comes. This is myasthenic patient. So just taking out the tumor or a lobe doesn't solve the problem. It has to be absolutely aggressive surgery, that is complete thymectomy. We should not go out of the standard, mode of therapy. We should not do anything short of that. So complete thymectomy with all fats and tissue, whatever we do from the top to up to diaphragm and mediastinum. So both-sided thymus, it was done. Surgery is simple. It was just VATS thymectomy, making a couple of holes. That time I used to do both-sided VATS, and the whole thymus taken out with this tumor. So decision is very important, that when the patient is having myasthenia of short duration, initially was asymptomatic, then a tumor has been dissected, tumor has been confirmed in a CT, it should be resected, but simply not taking out tumor. It should be taken, the whole thing has to be taken out, as should be done in a myasthenic patient. Another extreme of thymoma, let me tell you about 3 girls that came to me in same week, all in the age group of 17, 18, all are class 12 girls, absolutely asymptomatic patients. They had lower respiratory infection, cough and cold, and they were sensible girls. One father of one girl was a doctor, so she had one chest X-ray, and then whole casket open. This is the picture. Huge tumor, occupied everything. So this is the picture. These are the picture. The whole sheet of tumor, all the structures, the airway, major vessels, everything are part of the tumor. This is thymoma, and this is very, very slowly growing tumor. And the tumor, the treatment is resection, this is debulking. So debulking is challenging in the sense here, our issue is to resect the tumor and protect the structure. And while resecting, we must be careful to protect all the structure, the major vessel, the airway. We have to keep a safe tissue and should not injure anything, because if it is injured, sutures will not take. And once it is resected, these are very, very slow growing tumor. Couple of thymomas, they are radiosensitive. After resection, radiation can be given. Radiotherapy is needed for something, but primary treatment is surgical resection, and in some cases, regrowth may be handled with resurgery, re-resection. But primary resection is very important. So when some patient comes with recurrent, maybe respiratory tract infection not responding to conventional therapy, so it has to be worked out properly, X-ray, CT scan. Once this sort of tumor comes, the treatment has to be decided and debulking has to be done. In these cases, sternotomy is standard procedure. Other modes can also be done. So here, 2 issues are important, challenging. There is enough resection to be done. Otherwise, symptomatic relief doesn't happen. The veins are compressed, the superior vena cava syndrome, lungs are compressed, the pericardium, heart is compressed. So enough resection has to be taken, but we must be careful that we should not injure in structure. So enough resection and safeguard the major vessel. These are the challenges, and debulking is the target. So this is one of the tumors getting resected like this, and once it is resected, the whole thing, including the pericardium, the tumor in front of major vessels, everything is resected, and it is okay. So I will now take you to another lesion that is also very uncommon lesion, but very important and challenging. That is bilateral lymphoma. Normally we handle lymphoma, maybe tubercular or non-tubercular. This is usually one-sided. Bilateral lymphoma is not common. It happens not very commonly, and mostly it is treated medically, either aspiration or drain. But sometimes it may take the course of chronic lymphoma, lot of loculation, thick wall, lung gets stuck, and the atelectasis. And these are the cases where these are the clinical issues. So uncommon clinical entity, bilateral lymphoma, they come with progressive respiratory distress, infection and progressive distress. If you look at the picture, so this is the X-ray picture, looks like as if there's effusion on both sides. Then look at the CT. There are very few, very small amount of lung tissue there. Lot of areas consolidated. These are consolidated area, and this is the normal lung. Other side is like this. If you look at different cuts, little lung is left. Major area lung is consolidated. This is the thick walled. This is thick walled collection. Little bit of lung, some consolidation. So bilateral lymphoma is a very, very challenging clinical entity. Sometimes you get it. This is not rare, but it is also not very common, but not very rare. Many times we get this sort of lymphoma, but fortunately, most of the bilateral lymphoma are amenable by medical therapy. They are treated by medicine, that antibiotic, nebulization, chest physiotherapy, breathing exercise, and aspiration, and IC drainage in time. These are the things you can manage, but sometimes this sort of loculated bilateral lymphoma with lot of thick tissue, thick peel, and this sort of lung, we have to undertake surgery. This surgery, by convention, it may be stage surgery, one side done, then the other side, but both sides can be done together. And here, the bilateral lymphoma can be very, very nicely tackled with minimal invasive bilateral VATS. Both sides together. VATS or robot-assisted surgery, both can be done. Those who are experienced in robot is a very good option for them. And VATS, yes, it can be done in a multiportal VAT or uniportal VAT, or even the conventional, the traditional surgery of thoracotomy, one side followed by other side. So both sides can be done in the same sitting, but if it is done in stage, there is also no harm. But what I want to stress here, the bilateral lymphoma is a known clinical entity. We must be done properly. So challenges while we working in bilateral lymphoma, we have to be very, very careful while dissection. We cannot afford to do lot of lung injury, lot of air leak, and result in lot of continuous air leak for long time and bronchial fistula. Those are the major challenges, and whether we'll be taking one-sided or both-sided, one after another, that is the individual clinical case we have to decide. But what I want to stress here, that this may be as a sequel of tuberculosis, or it is non-specific. Sometimes secondary infection happening on tubercular pleural effusion. So whether it is tubercular or non-tubercular, mostly these patients are diabetic patient, hyperthyroid patient, sometimes obese women. So these are the background, comorbids. Diabetic patients are more prone, obese are more prone, hyper are more prone, and tubercular, either active tuberculosis or they are follow-up sequelae tuberculosis, or sometimes very resistant sort of bacteria. And sometimes it may happen due to associated other infective illness. Whatever it is, bilateral lymphoma is a clinical entity which is known, must be worked out thoroughly, must be handled properly, and must be operated. It can be operated at a one sitting or two sittings, either by standard thoracotomy, standard opening, or by minimal invasive. But it is a surgical case and it must be operated thoroughly. I think I should stop here. And these are the couple of challenges, couple of issues which are case specific, be it hemoptysis, be it infective, and be it ruptured heredity, I have not discussed it here, and be it very, very serious post-intubation tracheal stenosis. So whatever may be the challenging issues, the diagnostic part, imaging, that is very important. Then find out the route through which we are entering, either conventional or minimally invasive. But the basic thing is disease must be corrected. There should be no compromise. Whatever route we enter, we must be able to take out the disease. Of course, taking care of lung conservation. Lung is a very, very important organ, very delicate organ. We cannot resect lung, and we have to preserve as much lung as possible. With this, I think I should stop here. And I'm very sorry that we had a lot of wasting of time in the beginning. And now let us discuss whatever problems we have. I have just opened a couple of clinical issues which bring you to the picture of challenges in thoracic surgery.
Oh, fantastic talk, sir. Fantastic talk. Can I ask you to stop sharing your screen?
Yes.
And then we'll both come on the screen.
Just hold on.
At the bottom, yes,
Yes.
there is a green button which says screen share. So you have to stop sharing.
A lot of problems are happening.
Don't worry about it. Okay, I will do it for you.
How can you see it now?
I'll do it. I have got control. All right, sir. Okay. So thank you very much for a lovely talk, sir. Now I will start the question answers if that's okay with you. Have we got some more time, sir? Is it
Yes,
okay
sir,
to ask you a few questions?
Whole night is
Okay.
ahead. Whole night.
I can continue all night, sir. People know I can talk a lot. Okay, sir. So the first question I want to ask you, I'm going to go through each of these cases. This is a fantastic array of cases that you have shown us from your own experience. And I'm going to ask you specific questions about each of these cases. So let's start with the last one which you showed, bilateral empyema.
Yes.
So this is for the young students who are there on the audience. If you come across a bilateral empyema, what is your first line of treatment? Do you operate on them or should you go conservative management, chest drain both sides?
So when we come back to bilateral empyema, these cases had enough medical treatment. All these cases which I have recorded in my series, all of them were treated by pulmonologist, physician, antibiotic, aspiration. And once they came to me, they have been reviewed very nicely by imaging. I have reviewed the CT scan, I have done bronchoscopy, I have checked it. In most of the cases, there are thick pill, multiple localized collection, and there is lung consolidation. But then these are the cases where the thick pill and consolidated lung and loculated collection, surgery has to be done. Lung will not come up, and there is a lot of volume loss. So these are the cases where surgical intent is very clear. You have to operate.
Sure. So for the young surgeons, as sir said, the first management of bilateral empyema is medical. That is the most important thing. Okay. So you have to make sure that both sides are drained. Don't jump into surgery straight away. You have to give them a fair trial of antibiotics, a fair trial of ICD drainage. And then when all medical treatment fails, then you consider surgery. Now, my next question in this patient, sir, to you is, what are the problems of bilateral thoracotomy? Are there any issues with doing a bilateral thoracotomy on a patient?
Yes, bilateral thoracotomy has to be done very carefully because, you know, thoracotomy is a surgery which gives a lot of pain, lot of problem in post-op period. So normally in all thoracic cases, we are now habituated in pain relief by epidural, continuous epidural, or there are other modalities. Bilateral thoracotomy is not routine, should not be done casually, should not be done by beginners. Bilateral thoracotomy, I practice in two cases only, two types of cases. One is bilateral hydatid, left side hydatid, right side hydatid, and liver hydatid. By making ampullateral, but making 30-degree turn on one side, take the hydatid, sternotomy, take the liver hydatid, go to the other side. Thoracotomy is small, and we can manage all the lesions in spite of going into 3 sittings. That is one indication. Next is bilateral empyema. Lungs are consolidated. Lung is already very small volume lung. There are a lot of pus. And unless you are able to handle both sides, this infection will persist and all the sequelae of lung infection will happen. And more so, these lung being consolidated, the patient will have respiratory problems. So we have to do early. So one way is to operate one side, wait for some time, but during that period, patient will not be disease free. He will be febrile, he will be toxic, he will have problem. So these cases, my preference will be if this surgeon is experienced in VATS, that will be better option here. Ordinarily, it is thought that VATS is not indicated in empyema. I don't believe it, and I am sure you believe it much more than I do. That minimal invasive surgery is more indicated for these dirty cases. It may take a little more time. The surgeon must be a little more experienced. But once you are habituated to handle in a minimal invasive, you will love it. So bilateral empyema, I would love to go by minimal invasive. Here I want to put you. There are a couple of instances where I could not make both the lungs well expanded. One side done nicely, other side partially expanded, put it and come out. Patient settles, infection goes, and I went next sitting, that is in bad. So bilateral thoracotomy has to be done very carefully. Lot of pain, lot of problems happen posteriorly. It must be very selective.
Okay, so you said that you got to be selective about doing bilateral thoracotomy. Now I'm going to put you on the spot by saying that pain is okay. That is, we can deal with analgesia and all that. But what about air leak? You've operated on the left side. You have got bilateral empyema. In your patient, we saw there was more on the left, little bit on the right. When you did the decortication on the left, there was a lot of air leak, really a lot of air leak. And you left in 2 chest drains and you came out. Now, is there any reason why you would not do the right side, or would you still continue to do the right side by thoracotomy?
Your concern is very valid. So the side which we attempt first, we must be very careful to keep air leak minimal. If it is lot of air leak, it is very difficult to proceed further. So first side must be careful. We can accept a little more air leak on the next side. But primary requirement of doing bilateral, you must keep air leak in a very minimal. Otherwise you won't be able to handle. Bilateral air leak, putting the patient on positive ventilator will be another disaster. So it must be taken very, very carefully.
So sometimes on table, you might actually decide that it's not safe to go onto the other side because this side is not stabilized at the moment. Is that correct?
Let me interrupt you again. What I told you, probably younger people have noticed it. Sometimes I accept suboptimal decortication. Lot of pus, patient toxic, lung is not absolutely caught. So do one side, say one lobe is expanded, there is some pocket. Leave it, come and take in next sitting. Particularly in elderly patient, diabetic patient, with bad risk patient, sometimes we have to accept suboptimal outcome after decortication where we have to take it further. So bilateral is also very, very difficult decision, challenging decision, and I would suggest young kids not to venture unless they are a little bit more experienced.
Okay, so that's a very, very good point, sir. Now the next question is on the same bilateral situation. If you have got bilateral hydrated cyst, which side would you go in first and why?
This is very, very difficult question. Practically, there is no single answer for that. I tried both the things. First, let me tell you, if it is one side, big cyst, or one side, multiple cyst, this side with infected cyst, a cyst with complication or big cyst, usually I would like to take that side first. The cyst which is small and more so the cyst on more superficial, on the surface, on the lower lobe or in the fissure, cyst should be easily accessible. It should be big, infected. More so if it is left and right. If one cyst is well inside the lung and other cyst is surface, I will take the surfaces first. I will take it, do it nicely, close the bronchial orifices and do the capitonage. It is nice, no, not much leak. Then take the other side. And if it is right side, I would like to, if it is in the right lobe of liver, sitting above, and many times these are infected, not much thick tissue on the top. It can be opened nicely, resected, and one then putting below, one then putting above. So bilateral, which side first is a difficult decision, but these are the points, these are the things I take into account.
Yeah, sure. So just to summarize for the young audience in the group, bilateral thoracotomy is a very difficult decision. In empyema, if you go to the side that is worse first, and as Sir has said, you try to minimize air leak on the side that you're operating. That is the most important thing. Sometimes if the air leak is massive, then you can actually abandon the other side and just leave a chest drain and come out. But the problem is the infection persists. And the second point about hydrated is, Sir has said that you choose the side which has got problems, as in an impending rupture or a large cyst on one side, which will probably rupture if you operate on the other side. So these are the sort of things. Or if cyst is superficial on one side, then you go to that side first so that you can get rid of the cyst. Now, my question to you, sir, is instead of doing bilateral thoracotomy, could you possibly do a sternotomy and access both the lungs?
Yes, yes.
Would
no
that
problem.
not be less painful for the patient?
Dr. Ravi, it's a good option. I have tried in a couple of patients. I have done it. So sternotomy can be nicely, if it is bilateral cyst. In some cases, we get multiple cysts. The right lung, one cyst in the lower lobe, one cyst upper lobe, one mediastinal cyst, one is left side. In occasions, we get multiple cysts. These are the cases where sternotomy is a good option. Sternotomy has not yet been discarded for bilateral disease. A sternotomy should be reserved, and you are absolutely right. I fully agree. These gives you much less pain than bilateral thoracotomy. It gives you ease in finding out, and with small anterolateral thoracotomy, unless the cyst in the lower lobe, you have to struggle quite a bit. So for doing both sided cyst in the upper lobe or middle lobe or in depth of the lung, definitely sternotomy is a good option for multiple cysts on both sides. I fully agree with you. So as I told you, that it is a challenge to decide which way you are taking. For multiple hydrated, options are sternotomy, bilateral thoracotomy, rats and robots. Rats and robots are definitely much better technique, but those are for selected cases also. So for hydrated, it is very, very selective, and you have to justify in all individual cases.
But you would not do a sternotomy in bilateral empyema. That you don't want to do.
No.
Because
empyema,
you don't want
yes.
to infect the midline.
No. Empyema, I never do. It is bilateral empyema, I never go. And empyema, as I told you, I do sometimes accept compromise. Operating on one side, put a drain, not fully expanded, come out, go to second sitting. Patients are toxic, not able to breathe, not a lot of lung tissue available. So one side, say good decortication, other side reasonable, at least to clear the cavity, good drains, maybe thick drains, 2 on each side. It may be looking very horrible. It may give a lot of pain. We have to take care of pain. But draining the abscess, allowing the lung to expand, continue conservative therapy, and to follow up, if required, you may go for second sitting. That is the option. You can do it, but never sternotomy.
Okay. So that is quite clear that you don't go via sternotomy in an infective case. One of the participants is asking whether do you extubate your decortications on table?
Most of the patients are decorted on table, and lungs, and at the end of decortication, whatever mode of entry we take, in most of the cases, lungs are well expanded, air leaks under control. That is a reasonable outcome. At the end of the surgery, this is what we expect. So very, very few cases where there is earlier comorbidity, patients are toxic, there are other reasons. But per se for decortication, putting the patient on ventilator, coming out, not required. It is all extubated.
Not required. Most of them we extubate, and that has been my practice as well. In fact, I stay in theater till the anesthetist extubate. I want to make sure that they extubate.
That is one
okay,
issue.
Sir. So,
just have interrupted you. You have pointed out very valid point for youngsters. In thoracic surgery, all these cases may be bilateral empyema or one-side empyema or decortication or hydrated, whatever you do. Our practice is to be in OT before any work is done. So as I discussed about congenital lobar emphysema, you may need to undergo emergency, and thoracic surgeon are supposed to be very convenient in entering airway. Anesthetists may fail to enter airway. You can put a bronchoscope, you can do a tracheostomy. So thoracic surgeons must be in the OT as soon as patient is taken, must not leave the OT before patient leaves. Any emergency.
Absolutely. Absolutely, sir. I completely agree with you on that one. Cannot stress this many times. I mean, sir is so senior, but he will still stay till the end of the operation. Don't go out there and start drinking tea and coffee. The real complications happen just before start of the case and just after finishing the case.
Exactly.
So you've got to be physically present in theater at both these times, because you might have to urgently give airway access to the anesthetist. I completely agree with sir that our experience of doing rigid bronchoscopy actually puts us in a better position to deal with any airway problems. Sometimes we are more experienced than the anesthetist to give airway access. And I have been in this situation where I have had to intubate for the anesthetist. So you're absolutely right, sir. I agree with you on that one. Let's move to the next case that you presented, sir. I'm going to ask you a question about thymoma. You did a beautiful case presentation on that lady with a large thymoma, the 17-year-old girl. So my question now is going to be, one by one, I'm going to ask specific questions about that case. So looking at the CT, it looked like it was a very big thymoma, seemed to be invading a lot of the surrounding structures and seemed to be invading the vessels. So would you have preferred to give chemotherapy first and then follow it with surgery? Or why did you operate first? That's the question. For the youngsters, I want you to answer this question. What was your thought process when you operated and did what you called as debulking?
That is very valid concern. So these decisions are taken by a team consisting of oncologists with us. So it was discussed, and initially FNS was done, then true cut biopsy was done, then immunohistochemistry was done. The type of tumor that was identified out of these three cases, one case was radiosensitive. And that also they suggested it is not highly sensitive and the patient is already having superior metastasis syndrome. To debulk carefully, then we will go for radiotherapy. That patient was on radiotherapy. Other two patients out of them, one had nothing and one had chemotherapy. And since the tumor was very big, pressing on all the structures, only thing is we have to be very careful to resect, rather to leave some tissue, because there is no point in very aggressive. Mostly we have to debulk tissue very carefully on the major veins, large veins. That has to be cleared, otherwise patient don't come out. And then airway, we must be careful not to injure. Mostly the chance of injury of the major veins and then airways, these are the structures. It is difficult to injure the arteries. Aorta is difficult to injure. Mostly superior vena cava and the trachea, those are the structures. So here, this operating surgeon must be very careful, rather leave some little more tissue. Target is to take away pressure, to come out for the superior vena cava syndrome, and give the oncologist a chance to handle it with radiotherapy or chemotherapy, which is more suitable. Once you are able, because Zamir, we have seen one thing, a lot of times FNSC information is not enough and they are not able to take a decision. Then we go for treatment. Once you are able to get out a lot of tissue, then proper histopathology, then immunohistochemistry gives you full information for different parts of the tumor, and then the rest of the things can be decided. So that is the reason. Since these are very desperate cases, putting a lot of pressure, so debulking was taken. But this is not the first choice. Is the tumor is little smaller? If some definite decision get taken out, radiotherapy definitely the first choice. These are desperate cases where you have to do it.
Okay. So just for the youngsters, that if you've got bad cases like this, you have two lines of management. One is you can give chemotherapy before, downstage the tumor, and then operate so that you can take away more of the tumor and your resection lines become clear. And the second is if the patient is desperately unwell and there is compression and you have no other choice, then you go in by surgery and you debulk the tumor, you leave little cuff behind on the major vessels. And then when you treat them with post-operative radiotherapy or chemotherapy, you get maximal results. So there are two lines of thought process, and either of them is okay. The decision is made on table and the decision is made by the operating surgeon. Does that summarize your thought process, sir?
Dr. Zavir, regarding this issue, you have pointed out a very, very important issue that while debulking this tumor, tissue should be left on vital structure. It is just to relieve pressure. That is one issue. And another issue I should point out that while opening the chest, this sternotomy, that part must be done very carefully. These tumors, they push the major veins in front. The anatomy, major vascular anatomy is totally distorted. If some emergency injury of the vessel happens during opening, you are unable to control. So it must be careful. A lot of time, as we do in cardiac surgery, redo cases, that is oscillating sort, taking care of the posterior. So opening is very important. And the decision how much to debulk. So you have rightly pointed out that for these tumors, radiotherapy, chemotherapy, these are the options. But in huge tumor, it has to be debulked. But decision must be planned. It is not that patient came, operated, done, sent. It is a joint decision. If it is manageable and the tumor biology is suitable for chemotherapy or radiotherapy, so neoadjuvant therapy, then surgery, that is best option. And some tumors may absolutely dissolve, just like say small cell carcinoma type of tumor, that is not medicinal tumor, but that sort of tumor. Those are the fully curable by radiotherapy, chemotherapy. But in thymoma, these are very rare occurrences. So histopathology and immunohistochemistry give full information, and debulking or these sort of surgery reserved only for debulking, making the patient symptomless and allowing them to be treated by adequate chemotherapy.
Okay. Just a small point which I would like to add to this, sir. Whenever I operate on patients like these, which sir had shown, the one philosophy I always keep in theater is I prepare the groin and I will have a cardiopulmonary bypass machine primed and in my theater standby. Because as sir said, when you do the sternotomy, you can inadvertently damage structures because the anatomy is distorted. And so you've got to be prepared to just pack it off. If bleeding happens, you don't do anything more. You just pack it off and go into the groin and go on bypass. Control the circulation. And then once you've gone on bypass, then you continue to open the chest. The important thing is don't push in and try to open in the face of a massive bleeding, because you don't know where the bleeding is coming from. And when you try to open a chest, you lose a huge volume of blood. So if ever you're opening a chest, sir said use a circular saw, completely agree with him. And the moment you face the bleeding, just pack it with lots of pack, open up the groin, put in your 2 cannulas, go on bypass. The moment you're on bypass, then you get a cell saver given to the top end, and then start sucking into the cell saver, and then you open the chest. Then you continue opening the chest. It's very important to know what to do when the massive bleeding happens.
You are right. Let me just take a couple of seconds. This is absolutely right thing you have pointed out. And normally what happens in cardiothoracic surgery, if it is cardiothoracic department, the next thought is cardiac, having heart-lung machine is fine. If it is cardiac is not available, before taking this sort of patient, bypass must be ready. I fully agree with you. And youngsters, who are operating in exclusive thoracic centers, not having cardiac facility regularly in that center, before taking this patient, they must be careful. Very, very valid point you have pointed out. This is absolutely.
Yeah. So that's the second case that we've discussed. Now let's go down to the other one where you spoke about destroyed lungs. I love that one. One of the questions which the audience has asked is, when you're dealing with destroyed lungs, is it safer to go by sternotomy?
Here, you just cannot reach. It's difficult to enter. I have tried. Earlier, I have tried. But now what I do, I look this CT plate in console. I do pulmonary angio, CT angio. Sit in the console, find out the area where the major vessel, like aneurysmal pulmonary artery, or in that picture I have shown one connection between the pulmonary artery and the systemic arterial system. So periphery is covered by a huge bamboo-like pulmonary artery. So I find out the area and keep printed in my mind that which area I have to enter. Initially make a small incision. Once I am able to do that, then sometimes I take the help of a camera at that level. That's the one port you enter. That is nicely visible. That helps. There is some sort of hybrid setup. I should say some improvised Indian technique. So whatever way. So entry point must be very careful. If we make some injury of the vessel at this point of time, just you cannot do anything. So that is a major issue. And sternotomy doesn't help. I was not comfortable.
No, I agree with you, sir. I would like to share my experience with these cases with destroyed lungs. I am a strong believer that actually, and that's been my experience as well, that in these cases, though the CT looks really ghastly, VATS is a very good tool, and robotic is a very good tool to dissect that destroyed lung off the chest wall. So a lot of people think that, no, this badly destroyed lung, we should just open the chest. In fact, going in by thoracotomy is much more difficult in a completely destroyed lung, because you cannot see where you are dissecting. Whereas with VATS, if you have enough experience with doing infective surgery cases, then you learn how to get into the chest. The first port is the most important. And then once you've got in the first port and you operate in a uniportal fashion, then you can actually dissect all the adhesions of the chest wall under vision. And when you dissect adhesions under vision, the bleeding is less. And so slowly, you go to the second port and then guide your way into the third port. And once you've got 3 ports, then all dissections can be done under guided vision. So the bleeding is less. And most of the dissection is millimeter by millimeter. At this stage, I usually dock in the robot. And then the robot's ability to move 360 degrees actually gives you better access around all these adhesions, particularly at the thoracic outlet, at the apex of the lung, where there are a lot of collaterals which come in. Again, at the hilum, a point which I'd like to make is you can either go at the hilum extrapericardially, but sometimes in these badly destroyed lungs, it's a lot more easier to just open the pericardium, and inside there is no adhesion. And so inside, once you open the pericardium, it is all pretty free to get around the vascular structures. Sir, do you agree, or do you disagree?
Yes, you have pointed out very, very nice thing. 2 things you have pointed out. Let me clarify. One is entering through VATS. People believe that these are not amenable to VATS. I already pointed out that first looking at images, I make a print on my brain that which area I have to make the first port enter. Rest of the dissection, VATS is very, very comfortable. I have no experience in robot, and I believe robot will be much better, much helpful. This will allow you to make dissection apex. Apex is most notorious area. Lot of area and lot of problems happen there. And in desperate cases, you have pointed out, let me add one word only. After making dissection, central part has always got less adhesion. And if you go through pericardium, just access through pericardium, whole job becomes much easier. And definitely with experience, young people will learn this. So first enter, use VATS or robot, and in desperate cases, there's no heroism. Go through pericardium. That makes your life safe and you won't lose patient. Even in these dirty patients, if you keep your mind open to switch on to any technique, we have got all weapons, use it, and all the patients can be saved. But you must keep your mind open. All these options are absolutely valid, must be done.
Okay. Sir, now the next case that you discussed with us was a lung abscess. I just want you to clarify for the young surgeons very clearly what are indications for surgery in lung abscess. You know, which are the patients you manage conservatively, which are the patients you decide to take to theater, and why do you decide to take to theater?
That I wanted to clarify, because per se lung abscess is not an indication for surgery. It must be managed medically. So very, very short course, aggressive course. The conservative treatment has been done very nicely. Adequate antibiotic, chest physiotherapy, then the steam inhalation, partial drainage, and I prefer to do bronchoscopy, fibroscopy, bronchoscopy routinely, sometimes number of times. So everything being done, you are unable to bring down temperature. Unable to, the temperature keeps every day 2, 3, 4 temperatures. In spite of a lot of paracetamol, you are unable to bring temperature. Patient is toxic, CRP is going high. And if you look at it, I will insist the youngsters to make use of this stethoscope. I am a old timer. So listening every time, you find the area does not get aerated. It is having a lot of bronchi, lot of plates, a specific area, maybe one area on the wall of what I showed, that never improved. Patient is toxic, temperature is high, CRP is high, producing a lot of sputum, that is not improving. Did serial X-ray, then one city earlier, after 10 days another city, and showing a lot of distraction. Then I thought, let me go, let me take out. But this decision must be taken carefully, not that I do it very frequently. And but sometimes, if lung abscess cannot be managed, it is aggressive cause, and more so, what I pointed out, that there is, background disease, that is comorbid. A diabetic patient, a hypothyroid patient, a short, fatty young female, those are more important subjects. Edentulous elderly, I got one patient, edentulous elderly, who probably had bronchopneumonia sort of thing, something entered while drinking. So these are the couple of background things may be there, but mostly if the clinical course is very, very aggressive and there is no improvement in aeration of a specific area, that is the major issue. That is a challenge. You have to take a decision that probably it is not working. And once I had a very difficult issue to decide. Then I thought, in earlier days we see that is not done now, that exploratory lobotomy. So it is just like that. So sometimes if you are convinced that your all measures have failed, it is not improving, don't hesitate. And today it is very, very comfortable. Put a port, see nicely. And that is a very good option. And I have reviewed, rather, I should say that I have revisited the indication of thoracoscopy at the flag end of life. That earlier I thought in the beginning that infective cases, redo cases, these difficult cavities, they are not suitable for thoracoscopy. But now I have reviewed the difficult cases. You go.
I am so happy you think like that, sir. Okay, now I'm going to ask you a question, sir. In the lung abscess, you have gone into the chest and you have an area, say in the lower lobe. Would you prefer to do a lobectomy, or would you prefer to wedge out a lung abscess, giving the, keeping in mind that the lung tissue is not in great condition and your staplers may not hold? So would you wedge it out, or would you do a lobectomy, which would be a safer option in lung?
Your concern is absolutely right, and I believe in the same philosophy. As much as lung has to be protected, and wedging or suturing, whatever you do, that will not be very easy and safe in these cases. So you have to play very safe. Conservative lung, that is the idea. So we have reviewed this CT in console. That if there is one segment is left, yes, we have to protect it. If it is localized in 1-2 segments, if all the segments are not involved, there is reasonable lung tissue, definitely it should be better to go for conservative resection. You may go for wedging the lung. If it is still more bigger, you can go for segmental resection. In these cases, what I showed, the whole lobe is gone. This is desperate, but always we must try to protect lung by wedging or by segmentation. Definitely that is better option.
But are you worried that your staplers may not take on the bad lungs?
Yes, and let me tell you, as a old timer, in these cases, I go for hand suturing.
Hand suturing. Okay. All right. Very good. Excellent. Is there any role for percutaneous drainage of lung abscess?
Percutaneous lung abscess, yes, there is a very limited role. I can recollect a couple of experiences. Normally, the abscess, which is close to the surface, ruptures and makes a pleural empyema. Sometimes these empyema percolates to the intercostal space and comes out in subcutaneous plane also. That is another complication. So if the lung abscess is exactly on the surface, and one more thing, the lung is adhered in this infected abscess, they are adhered to the chest wall. Either it has ruptured in the pleural cavity or it is adhered. If you can locate, and here USG is a very good guide. USG will show you in the chest wall it is adhered. You put a needle, you straight go into abscess cavity. So a toxic patient having very bad sort of lung abscess, having a lot of other comorbids, putting a drain temporarily, it is a temporary option, it's a good option, but it has to be localized nicely.
Okay, all right. So that's quite clear to the youngsters, I hope. We move on to the next case that you discussed. Is it okay, sir? Can we do this case by case?
Yes, a lot of time.
Yeah, so we move on to the next case that you discussed, hemoptysis, massive hemoptysis. So two questions. One question was actually asked to me on the group mail. Is there any role for pulmonary function test in a patient with massive hemoptysis? You're going to go to theater. Should you bother doing PFTs, or should you just go ahead and save life? This is the question which a student asked me.
So let me answer this question first. If you allow me, let me be a little bit blunt. So
yes,
patient is bleeding terribly. That is going to kill your patient. Whatever be your lung function, you have to go.
Yes.
Let me tell you, in your destroyed lung function is just unbelievably bad. But that lung is not adding to your oxygenation. So once you take out the lung, the whole blood goes to the other lung and your oxygenation improves. So these are the cases. Definitely lung function will help you to guide to manage during surgery. Pre-op means before induction of surgery, this lung function will make your life stormy and the cells will be in trouble. You have to manage it. So lung function parameters will take you through this phase, but surgery is a must, and whatever works with lung function, you have to operate.
So just to clarify for the audience, this is the only situation in thoracic surgery where you are going to go in and do a major lung resection, but you don't bother with PFTs.
Yes.
You just go in and save the life of the patient.
That is, I use the term, let me be a little bit blunt and desperate.
Absolutely. Sir, somebody is asking, what is the success rate of bronchial artery embolization in massive hemoptysis?
In bronchial artery embolization, massive hemoptysis always plays a limited role. It gives you some time, it purchases some time for you. You get some time to make the patient little bit fit, little bit better, avoid emergency surgery. But in massive hemoptysis, where there are a lot of neovascularization, a lot of connection, you cannot identify thousands of vessels and embolize them. It doesn't work. But some bleeding vessel, blush is there, that you can block it temporarily. That gives you some time to get ready for the surgery. That is the benefit. It does not give you permanent cure. Massive hemoptysis, you need surgery. This is just interim process, purchase some time. This is my feeling.
Yeah, no, I agree with you, sir. The problem is most of the papers that are published for bronchial artery embolization are published by radiologists, interventional radiologists, and they are published in interventional radiology journals, which are not read by surgeons. So if you read those papers, they quote a success rate of 90 to 95%. But blocking one vessel doesn't impact the outcome in the patient. So I completely agree with you that actually it is a temporarizing method. Most of these guys will rebleed. There will be multiple collaterals which will cause a problem. And so it gives you time to prepare the patient for surgery. But if the patient is desperately unwell and hemodynamically safe, you have to go in and solve the problem. There is no other way out. A BAE will only buy you some time, but eventually surgery is the answer.
You are right. Let me add a little bit. Very interesting story here. In the private hospital where I work, I have a very good pulmonologist and interventional radiologist there. So the good number of patients with hemoptysis we get. The patient which have got limited, limited anomaly, congenital anomaly, vascular anomalies, limited. Those cases are handled by them. The same person, the profuse hemoptysis, they handle it for us. To get some time, we prepare this. And those patients which are limited problems, those are permanently done and handled by them. So in our hospital, say in a year, they get X number of cases which have been done by them and cured. Those cases go for publication from their end, from pulmonologists.
Yes, absolutely right.
Both ends are right.
Absolutely right. So, yeah. So when you read literature on these things, you got to be a little careful. You have to understand what is the story behind the literature. So don't believe the numbers that you see in the paper straight away. Okay. Now my next question is: you spoke about CCAM. When these kids come with CCAM, do you operate on neonates or do you operate on them when they have grown up to a year or 2 years? What is your philosophy when you do CCAMs?
Congenital lobar emphysema.
Congenital lobar emphysema.
Incidentally, in my college Arjikar, in one period, I got quite a good number of cases. Thereafter, before that, 4 or 5 years, I didn't get. It is sporadically this case. One maybe relatively bigger series I have sent for publication in one journal. I have got absolutely very funny experience. Quite a good number of cases we get in a very, very early infancy, just within a week. 1 day, 2 days, 3 days, very small babies and grossly, desperately distressed. And the neonatology, they have done their best. And X-ray and CT is very deceiving. Looks like that is the healthy lung. Couple of cases are referred in very, very early infancy with a chest drain in, worsening further. So one group of patients you get in very early infancy within few days of life. Another group we get between 3 to 6 months of life. These are the major cases. Beyond 6 months, the classical congenital lobar emphysema is very, very infrequent. After 6 months, very few cases you get up to 5 years. And beyond that, some cases are reported in literature. I have scanned literature very thoroughly. They are very, very minimal lobar segmental, rather we should say segmental emphysema. They don't have a lot of impact on collapse. And what happens, there is compression atelectasis of the same side than the other side. When one lobe is totally gone, and let me add in here, why these lobes are so much hyperinflating, it is not known. It has been observed and proved in different studies that number of alveoli, they have got 5 times more than normal lobe. So if one healthy lobe has got say, X number of alveoli, this emphysematous lung will have 5x number of alveoli. But histopathologically, they are not much diseased. So still, it is not known why it happens. But it is either in the very early infancy, couple of days, or around 3 months, 3 to 6, and beyond that, no desperate cases. And so while the patients are diagnosed, are taken, they're desperately ill. Once you are sure the conjugal emphysema, we are just ready before the patient is taken. Somehow they inhale something, make an incision, whole lung tips out, and things settle. Rest of the surgery is very simple.
Now, sir, you have opened the chest in this baby, and the lung has come out and he has settled down. My question to you is, how do you know that the baby will thrive on the other lung? How do you know that the other lung will expand?
Then what happens? Usually it is one lobe, the same sided other lobe, anesthetic is inflated properly, sucked properly, it inflates properly. Then other side is ausculted while doing, they put the stethoscope fixed to that. Earlier, breath sound was a distance breath sound. It was atelectic, there's no sound. And now with ventilation, it sounds nicely. Clinically it sounds, and sometimes they check with ultrasound. Ultrasound has a limited role in thoracic surgery. This is the area the ultrasound probes helps you. So ultrasound will tell you, because CT you cannot do here. X-ray doesn't give you information immediately. So ultrasound probe will say that lung which was not aerating there, that lung is now functioning. And this side lobe you can see with your own eyes. And one more thing is seen very nicely, the mediastinal shift. When you opened, you see the mediastinal now in midline. So these are the couple of indirect evidence.
Sure. So the point I'm making to the juniors is that, you open the chest, but don't jump in and just take that lobe out. Make sure that the other lobe and the other side has re-expanded before you take any of this out. You have to clinically make sure that they have actually re-expanded. One question is from the audience. They are asking, what are the indications for completion pneumonectomy, and what are intraoperative challenges and techniques to control hilus structures? But they have to tell us why you're doing completion pneumonectomy, what scenario. So anyway, I'm going to ask you the question. What are the indications for completion pneumonectomy?
Yes.
Let's start with that.
Let me generate the rest of the question in this regard. I will make the question and answer. One is this completion pneumonectomy may be required for malignant disease, may be required for infective disease.
Sure.
Infective disease, if the patient is having, say, bronchiectatic cavity, many a times the bronchiectasis is a bilateral disease. So, couple of bronchial cavities, what he thought that may not be great. In the interest of saving the lung, we have done one lobectomy, knowing fully well some bronchial area is there. And the area involved there is some air leak. And since this segment or piece of lung tissue which is having air leak, but that is not getting inflated. If it is not inflated, that air leak will not stop. So continuing air leak, in spite of all efforts and nice surgery, due to residual disease being left there. It is infective disease, maybe consulted, maybe tubercular, maybe bronchiectasis. So that residual thing should be removed. And if it involves remaining lobe, and you are unable to say one or two segments will undergo rotation and necrosis, you cannot keep it. So remaining left out lung tissue in an infective condition, giving rise to continuous air leak and bronchial fistula. That is one of the indications in infective disorders. In malignant disease, if the disease is left, we take piece of bronchus, where we put the stapler, the remaining bronchus, site of resection at bronchus, if you get disease there. And sometimes air leak may continue from the remaining that end of the stapler or sutured area. So if the disease is affecting the resected bronchus and the lung, the remaining lung is not, say, if the middle lobe is left, that has undergone torsion, that needs, other lobes we have removed, middle lobe looked healthy, I have kept it. So that needs completion pneumonectomy. So mostly when the bronchus is involved by disease, infection, malignancy, infective condition, these are the indications of completion pneumonectomy, but must be decided very, very carefully. Pneumonectomy is a last resort, should be done very carefully, more so if it is right side.
Okay, very good. There's a very good point made by Dr. Faizul Islam, who is a pediatric cardiac surgeon. is a very important point. I think it has to be stressed again to all the audience that when you have patients with CCAM, just looking at an X-ray, you might think they have got pneumothorax. And so please be very careful before putting in an intercostal chest drain. Please think of a CCAM. Otherwise, you're in deep trouble. If a chest drain goes into the lung of a CCAM, that air leak is never going to stop, and it is going to make the patient worse. So very good point, Dr. Faisal Islam. Now, you've not discussed this here today, but I'm going to ask you a question on behalf of the students. Sir, you've done a lobectomy. You've done a right upper lobectomy. What are the strategies for ensuring that you don't get torsion of the lung? And if you do get torsion of the lung, how do you diagnose and how do you treat?
Torsion, usually there are a couple of prerequisites. If you leave mid-lobe, that is very, very notorious to undergo torsion. If it is infective disease, there is less chance of torsion. The additions keep it stuck. When you have done upper lobectomy, if lower lobe, if it is with middle lobe, what do you do? After surgery, the middle lobe and upper lobe are stuck together by a couple of stitches. Middle lobe left alone is notorious for torsion. Lower lobe left alone, separate. If it is left side, there's no middle lobe. So if there is middle lobe and lower lobe, they should be stuck together. And the torsion, prevention of torsion, one more thing we do, that is what is done in recurrent pleural effusion, the pleural tissue. So pleura is rubbed, it is made raw, and we must take care there is not much air leak, lung expands properly. Once the lung is expanded, it gets stuck. If the lung is collapsed for some time, there's more chance of getting torsion. So either middle lobe or non-expanded lung, these are the places where torsion takes place.
Sure. But in a post-operative patient, you suspect torsion, what should you do?
If torsion must be done, issue is X-ray doesn't give you much information. It is just collapsed lung. CT gives you a little bit more information. CT reconstruction will show the bronchus. That is clear. And fiber optic bronchus is very important. Yes. I would suggest that all thoracic surgeons must be very, very conversant with bronchoscope, both fiber optic and rigid. If you put a bronchoscope, torsion is very, very clearly seen. Rigid bronchoscope is a good answer. Rigid bronchoscope, it is main bronchus. We can put it. Fiber optic bronchoscope, you can go beyond that. Bronchoscopy give you full information. So putting the information of CT and then bronchoscopy. CT, you have to do CT means you have to go for CT 3D reconstruction. Reconstruction shows the airway. So CT reconstruction, and so let me put things in order. First, the patient is having persistently collapsed lung that is not expanding, which was shown expanded in the operation table. Post-op, your evidences, clinical and X-ray shows that it is not expanded. That's the first issue. Your oxygenation level, ABG level is not coming to desired level. Then you X-ray, it shows collapsed portion of that lung. Then CT 3D reconstruction, if you can do it, if the patient is suitable, if you have facilities, the 3D reconstruction shows the bronchial torsion, and bronchoscope gives you final answer. If you put bronchoscope, you can see nicely. So torsion, if it is diagnosed, if you leave it, it undergo necrosis. Patient gets toxic and lose the patient. If it is torsion, and if it is quite early, if you can open within 24 hours, it is not yet necrosed. Just suck it out, clean it, and fix it. Whatever air leak is, bronchial leak, you close it, and with positive pressure, lung expands. This flow will stay. If it is already congested, hepatization, and it is moving like this, don't leave it, take it out. So these are the major pulses following torsion.
Sure. So last question, sir, of the day is somebody's asking, in blunt injury of the chest with air leak, what is your approach to manage? Is it conservative or surgical? I think it's conservative, isn't it?
It is. It is always conservative. Surgery is
Always
done
conservative.
only when indicated. Only one point I add now, that we are sitting conservatively, but we must put a camera in to see. A lot of times I have opened after a couple of days, intercostal is bleeding terribly. That is going to kill the patient. So one other point, let me tell you, conservative, and in many cases, chest drain is required. So I have replaced that chest drain with a camera.
Oh,
The C camera, if something, just put a clip that sends up from the chest drain. So conservative, keep an eye, put a camera, see, and then surgery is limited to a very, very limited number of patients. Unless there's specific indication, there's no point in opening chest.
Okay. Well, one question I think I will take this is Dr. Akramul Haq is asking us, how can you make sure, this is going back to the pediatric surgery, how can you make sure that the lung will fill the space after lobectomy in infants? Are there any options of LVRS?
Let me answer it in my own way. LVRS, lung volume reduction, I believe there's no scope in pediatric patient. In pediatric patient, lung elasticity is very, very high. In pediatric patient, lung comes up very nicely. Only thing what we have to see after whatever surgery we have done, the ear leak, particularly bronchial leak, alveolar leak stops. If there is bronchial leak, that is going to give the bronchopleural fistula. If enough air leaks from the bronchus, the lung will not expand. If there is retained section inside, lung will not expand. So proper secretion, and on the operation table, we have to suture the bronchus, not the overlying lung. The bronchus has to be identified, it has either to be clipped or sutured. If the bronchus leak is closed, and on table, anesthetists will tell you about the volume loss on ventilation. If the volume loss is significant, means it is around 20% or more in the term. In adult patients, say 500, 600 tidal volume, you can afford to lose maybe 50, or maybe if the large lobe is gone, maybe 100. If the volume loss is significant, it is the indication you have to be careful. If there is not much volume loss, if there is not much bronchial leak, if the patient is able to maintain such on table, these are the cases you do. And with open eye, let me tell you what we see, that elasticity of the lung is expanding. We do two maneuvers. One is positive pressure. So give some more pip, some higher pressure, lung expands. This is one issue. And next, on normal ventilation, patient should get normal tidal under normal pressure. If it is able to feel more than 60-70%, almost 2/3 of chest is filling, there's no bronchial leak, the lung will come up. More so in pediatric patient. Adult has got
thank
some
you.
limit. Pediatric patient,
No rule for LVRS. Okay, sir. Sir, before we sign off, I just want to address one question which Dr. Thai Koko has written to us. He's saying, can he get the topic and password for the next few discussions? Dr. Thai Koko, my suggestion is that you need to join the Thoracic Guru's WhatsApp group. So email me your number and we'll try and add you. My personal email is azamirk@gmail.com. If you please email me, I will try and add you so that you get the future invitations for all the lectures. Thank you very much, sir. It's been an absolute honor and a privilege to be on the same platform as you to discuss all these very, very complex scenarios. You have taken us through some really amazing situations where a lot of us don't know what is the correct answer. Also, on this group, there are a lot of exam going students. So we tried to address the questions with regards to how they should answer in the exam. So some of the questions which we asked to you, sir, were actually directed on behalf of the exam going students, because these are the questions that come up in clinical discussions. So thank you very much. And we are really, really grateful for your time and your effort, and more importantly, the contribution that you made to thoracic surgery, not just in India, but across the world. Thank you once again, and I'm very pleased to let everybody know that sir is available with us tomorrow as well, and sir is going to do another talk on
Wow.
tracheobronchial foreign bodies.
Dr.
So-
Zamir, if you allow me a couple of seconds,
Sir,
let me
please.
let me express my sincere gratitude to all the listeners, all my friends, and
Yes,
I
sir.
sincerely apologize for the technical defect what happened.
That's all right. Don't worry, sir.
Wasted a lot of time. So tomorrow I am sure these things will not be there, and I am really grateful that people almost at midnight participating, taking lot of interest. They are sitting here. In India it is almost midnight. In your place it may be a little earlier, but spending more than 2 hours sitting across the table as we are sitting and discussing thoracic issue is really, really very, very enjoyable situation. And I'm really honored and grateful to all of you. And tomorrow definitely we are meeting. We will come up with another problem.
Indeed, sir.
Let us see.
Thank you. Thank you very much, sir, and good night to you, and good night to everybody else.
Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank you. Thank you.
Thank you, sir.
That was Shilpa, sir, for you.